Introduction. Good morning, everyone. Today we're examining one of the most profound yet under-recognized challenges facing healthcare professionals: moral trauma. While we extensively train clinicians in technical skills and even communication, we rarely prepare them for the deep psychological wounds that can result from the very practice of medicine itself. Moral trauma encompasses the psychological, emotional, and spiritual harm that occurs when individuals are unable to act in accordance with their deeply held moral values, or when they witness or participate in events that transgress their moral beliefs. In healthcare settings, this phenomenon has become increasingly prevalent, accelerated by systemic constraints, resource limitations, and the inherent tragic choices embedded in modern medicine. I. Defining the moral landscape. Key concepts. A. Moral distress. The concept of moral distress was first articulated by philosopher Andrew Jameson in 1984. He defined it as the psychological disequilibrium that occurs when one knows the ethically appropriate action to take, but feels constrained from taking it due to institutional, hierarchical, or resource-based obstacles. Consider a nurse who recognizes that continued aggressive treatment is causing suffering without benefit, yet feels powerless to advocate effectively against a physician's orders or family wishes. The nurse experiences the gap between what she knows should happen and what she can make happen. This gap creates a specific kind of suffering distinct from burnout or compassion fatigue. Key features of moral distress include a clear perception of the ethical course of action, external constraints preventing that action, and the resulting psychological burden. Research shows that repeated episodes of moral distress can accumulate, creating what some scholars call crescendo effect, or moral residue, where each new episode becomes harder to bear because it resonates with unresolved previous experiences. B. Moral injury. Moral injury, a term borrowed from military psychology, refers to the deep soul wound that occurs when someone perpetrates, witnesses, or fails to prevent acts that transgress their core moral beliefs. Unlike moral distress, which focuses on constraint and powerlessness, moral injury emphasizes the lasting damage to one's moral identity and worldview. The clinician who participates in what they perceive as futile or harmful treatment doesn't just feel distressed in the moment. They may experience lasting changes in how they view themselves, their profession, and their place in the moral universe. They may ask themselves, "What kind of person have I become?" Or, "How could I have been complicit in that?" Moral injury manifests through guilt, shame, spiritual crisis, loss of trust in institutions or colleagues, cynicism, and sometimes a profound sense of betrayal when the systems meant to support ethical care instead demand its compromise. It's important to note that moral injury can occur even when the individual has done nothing objectively wrong by professional standards. What matters is the violation of their own moral framework. C. Moral residue. Moral residue is the accumulation of unresolved feelings from morally distressing situations. Each compromised value, each patient whose suffering we couldn't adequately address, each family conversation where institutional policy prevented us from being fully honest leaves a trace. These traces don't necessarily dissipate with time. Instead, they can build up, making clinicians increasingly vulnerable to moral trauma. Think of moral residue as similar to psychological scarring. The tissue heals, but not quite the same as before, and each new injury to that same area becomes more damaging. 2. Sources and contexts of moral trauma in healthcare. A. End of life care nowhere. Is moral trauma more prevalent than in end of life care, particularly in intensive care settings? Studies show that ICU nurses experience profound moral distress when providing what they perceive as futile or torturous interventions. Imagine caring for a 95-year-old patient with advanced dementia, multiple organ failure, and terminal cancer who is receiving dialysis, mechanical ventilation, vasopressors, and repeated resuscitation attempts. The family insists on everything, perhaps driven by guilt, denial, or religious conviction. The healthcare team may be legally and institutionally required to continue treatment they believe constitutes patient harm. The trauma here is multifaceted. Clinicians may feel they're actively inflicting suffering rather than relieving it, violating the foundational principle of non maleficence. They may feel they're being forced to lie through their actions, as aggressive intervention in this context communicates hope where none realistically exists. They become instruments of a process they find morally abhorrent, yet professional duty requires their participation. B. Resource allocation and rationing. The COVID 19 pandemic brought crisis standards of care and explicit rationing into stark relief, but resource constraints create moral trauma daily in less dramatic ways. When we must choose between patients, when beneficial treatments are denied due to insurance limitations, when staffing shortages mean we cannot provide the care we know patients need, we experience the moral weight of scarcity. A physician who must tell a patient they cannot have a medication that would significantly improve their quality of life because their insurance won't cover it experiences a particular kind of moral injury. The system places them in the role of denying care, corrupting the therapeutic relationship, and violating their sense of professional duty. C. Institutional and hierarchical constraints. Healthcare occurs within complex hierarchical structures where power differentials can prevent moral action. Nurses may see problems that physicians dismiss, residents may disagree with attending physicians' decisions, and healthcare workers at all levels may feel unable to challenge institutional policies they find unethical. Consider the resident who witnesses a senior surgeon making a preventable error but fears retaliation if they speak up, or the social worker who knows that discharging a patient will lead to homelessness but has no alternative resources and faces pressure to free the hospital bed. These situations create moral trauma not from a single wrong choice, but from a system that makes right action impossible. D. Complicity in injustice. Healthcare workers increasingly recognize how they may be complicit in systemic injustices related to race, class, immigration status, disability, and other forms of marginalization. The emergency department nurse required to report undocumented patients, the psychiatrist participating in an insurance system that denies mental health parity, the primary care physician with only 15 minutes per patient in an underserved community, all may experience moral injury from their participation in unjust structures, even as they try to provide good care within them. E. Pediatric and neonatal care. Caring for children, particularly in situations where treatment may prolong suffering or where parental decisions seem harmful to the child's interests, creates intense moral trauma. The neonatologist providing invasive life support to a 22-week premature infant with virtually no chance of survival without profound disability. The pediatric oncologist administering chemotherapy unlikely to work while almost certain to cause suffering. The Child Protective Services worker unable to remove a child from a harmful situation due to legal constraints, all face the unique anguish of witnessing preventable harm to the most vulnerable. Third, consequences of moral trauma. A. Individual impact. The psychological consequences of moral trauma are profound and well documented. Clinicians experiencing moral injury may develop symptoms consistent with post-traumatic stress disorder, including intrusive thoughts, avoidance behaviors, hypervigilance, and negative alterations in cognition and mood. They may ruminate obsessively about cases, replay scenarios endlessly searching for what they could have done differently, and experience nightmares about patients. Depression and anxiety are common, as is a profound sense of shame. Unlike guilt, which focuses on I did something bad, shame centers on I am bad. This self condemnation can be particularly corrosive, leading to social withdrawal, substance use, and in tragic cases, suicide. Healthcare professionals have elevated suicide rates, and moral injury is increasingly recognized as a contributing factor. Moral trauma also manifests in what we might call spiritual or existential injury. Clinicians may lose faith in their profession, their institutions, or their ability to make a difference. The idealism that brought them to healthcare curdles into cynicism. They may feel fundamentally changed, as though something essential to their identity has been damaged or lost. B. Professional and systemic impact. Moral trauma drives clinicians from the profession at alarming rates. Studies suggest that moral distress is a stronger predictor of intention to leave nursing than workload or even compensation. We're losing experienced clinicians not because they can't handle the work, but because they can't bear the moral compromise the work increasingly demands. Those who remain may experience decreased job satisfaction, reduced engagement, and compassion fatigue. The quality of care suffers when providers are morally traumatized. They may become emotionally detached as a protective mechanism, losing the empathic connection that makes for good clinical care. They may cut ethical corners, thinking, what's the point when previous efforts to uphold standards have been thwarted? Some become cynically compliant, following protocols without moral engagement or advocacy. Moral trauma also damages the social fabric of healthcare teams. Trust erodes between colleagues, particularly along hierarchical lines. Healthcare workers may become isolated, suffering silently rather than sharing their struggles. The organizational culture becomes toxic, characterized by moral distress, normalization, where ethical compromise is simply how things are. IV. Moral repair and healing. A. Psychological approaches. Healing from moral trauma requires more than stress management or self care platitudes. It requires genuine moral repair, a process of reconstructing one's moral narrative and identity. Narrative reconstruction involves helping individuals tell the story of their moral trauma in ways that preserve moral agency and integrity, rather than being simply victims of circumstance or perpetrators of wrong. They can understand themselves as moral agents who faced impossible situations and made difficult choices within contexts not of their making. This doesn't excuse harm or eliminate responsibility, but it places individual actions within their proper systemic and situational context. For example, a physician might move from I killed that patient by withdrawing care to I was part of a deeply flawed system, and in an impossible situation, I made the best choice I could with the information and constraints I faced, even though the outcome was tragic. This reframing doesn't eliminate grief or regret, but it prevents the total collapse of moral self-worth. Meaning-centered therapy, drawing on Viktor Frankl's logotherapy, helps individuals find meaning even in moral trauma. The question shifts from how do I eliminate this suffering to what can this suffering teach me? How can I use this experience to become a better clinician, advocate, or person? Some clinicians channel their moral injury into activism, policy change, or teaching, transforming their pain into purpose. Crucially, psychological healing must include acceptance of moral residue. Not all moral distress can or should be resolved. Some moral wounds are the appropriate response to genuine tragedy or injustice. Accepting that we will carry some guilt, some regret, some sorrow is not pathology. It's the mark of a conscience that still functions. The goal isn't to eliminate moral residue, but to prevent it from becoming toxic shame or debilitating guilt. B. Religious and spiritual interventions. For many healthcare workers, moral trauma has an irreducibly spiritual dimension. They experience not just psychological distress, but a crisis of faith, meaning, or cosmic justice. Why does a good God allow such suffering? What meaning can be found in preventable deaths? How can I reconcile my participation in harm with my religious values? Chaplains trained in moral injury care can provide invaluable support. Unlike purely psychological interventions, spiritual care can address questions of ultimate meaning, divine forgiveness, and reconciliation with one's faith tradition. Many religious traditions have robust resources for dealing with moral failure and guilt, from Catholic confession and absolution to Jewish teshuvah to Buddhist practices of compassion for self and others. Rituals can be particularly powerful for moral repair. Rituals of lament acknowledge grief and injustice without requiring immediate resolution. They create space for honest expression of anger, sorrow, and moral outrage. Confessional rituals allow individuals to name their moral failures or complicity before a trusted witness, breaking the isolation of shame. Rituals of reconciliation can symbolize the reintegration of a fractured moral identity, marking the transition from moral injury toward healing. These spiritual interventions work best when they avoid cheap grace or premature closure. The chaplain who too quickly reassures God forgives you or you did your best may inadvertently minimize the real moral weight of the situation. Effective spiritual care honors the genuine moral complexity and allows for ongoing wrestling with difficult questions. V. Structural and systemic solutions. While individual healing is crucial, moral trauma is fundamentally a systems problem requiring systems solutions. A. Institutional changes. Healthcare organizations must move beyond rhetoric about self-care and resilience that places all responsibility on individual clinicians. True organizational commitment to reducing moral trauma requires structural changes in how decisions are made, how resources are allocated, how hierarchies operate, and how ethical concerns are surfaced and addressed. This might include ethics consultation services that are easily accessible and truly independent, ethics committees with representation from frontline clinicians, protected time for moral debriefing after difficult cases, and clear mechanisms for reporting ethical concerns without fear of retaliation. Organizations must create what ethicist Lori Zoloth calls epistemic justice, ensuring that those with direct patient care experience have genuine voice in institutional policy. B. Educational approaches. We must prepare healthcare professionals for the moral dimensions of their work with the same rigor we use for technical training. Medical and nursing education should include explicit discussion of moral distress, moral injury, and moral resilience. Students should learn not only how to recognize these phenomena, but also how to navigate morally distressing situations, advocate effectively, and seek support. Simulation-based education can be particularly valuable, allowing learners to practice difficult conversations, challenge hierarchies constructively, and make decisions in tragic choice scenarios without real-world consequences. Reflective practice sessions, Schwartz rounds, and narrative medicine approaches help develop the moral imagination and emotional awareness necessary for sustaining ethical practice over a career. C. Policy and advocacy. Ultimately, reducing moral trauma in healthcare requires addressing its root causes: inadequate resources, perverse financial incentives, unjust access to care, and legal frameworks that prioritize institutional protection over patient welfare. Healthcare professionals experiencing moral trauma should be supported in translating that experience into advocacy for systemic change. Professional organizations must take stronger stands on issues like safe staffing ratios, appropriate scope of practice, protection of clinical judgment from corporate interference, and healthcare justice. Individual moral repair is necessary but not sufficient. We must also repair the broken systems that reliably produce moral trauma. Conclusion: moral trauma in healthcare is not a sign of weakness or inadequate coping skills. It's the natural response of moral agents to morally injurious situations. In many ways, the capacity to experience moral distress is precisely what we want in healthcare professionals. It means their conscience still functions, they still care deeply about right and wrong, and they haven't become cynically indifferent. Our task is not to eliminate moral distress entirely. Some degree of moral discomfort is inevitable and even appropriate in a field that regularly confronts suffering, limitation, and tragic choices. Rather, our task is to prevent moral distress from accumulating into moral injury, to support those who are morally wounded, and most importantly, to address the systemic conditions that make moral trauma so pervasive. This requires a multi level approach encompassing individual, psychological, and spiritual support, institutional cultural change, professional education reform, and health policy advocacy. It requires us to take seriously the moral lives of healthcare professionals, recognizing that their well being is not separate from patient care quality but essential to it. As we conclude, I want to emphasize that if you're experiencing moral trauma, whether as a current clinician or in anticipation of practice, this is a legitimate form of suffering that deserves attention and care. Seek out trusted colleagues, mentors, or counselors. Find communities of moral support. Consider whether spiritual or religious resources might help. And remember that your moral sensitivity, even when it causes pain, is a professional asset, not a liability. Thank you. I'd be happy to discuss any questions or share your own experiences with these issues.